another COVID edition of our show today, and you can see we're filming outside. My guest today is Dr. Christine Arnold. Dr. Arnold is an OB-GYN with the Obstetrics and Gynecology of Akron Incorporated. She's also a clinical instructor at the Department of OB-GYN with Northeast Ohio Medical University. I've asked Dr. Arnold to be our guest today to talk specifically about things that happen with women as they begin aging. And we're going to start with a discussion of menopause. Dr. Arnold, thank you so much for being here.
Thank you for having me. I'm happy to be here.
All right. So, everyone I know, because I'm clearly over 60, has been through or very post or going through menopause. Why don't we start with this? Tell me a definition of it and what age it normally starts and so on.
Sure. So menopause, the technical definition is 12 months of not having a period. The perimenopause is the period of time before you hit that 12-month mark. So there's a period of time where the periods become irregular and women start having symptoms of menopause. But then once you reach that 1 year mark is when we officially say that you are menopausal. So the average age is about 51 in North America.
Oh.
The average age actually differs slightly, in different countries, but in North America, it's about 51. The average age of the perimenopause, though, is about 4 years prior to that. So around age 47 on average, women in the United States will start noticing some of those symptoms.
I never knew that. So why does it differ? We're a little off subject here, but I'm very curious.
So it's not well understood, but likely due to genetic reasons is the reason why it differs slightly, across the world. But 51 is when I tell my patients, on average, that's when they can expect to be going through the change. So,
and perimenopause, I remember as being sort of an odd time.
Very odd.
It seemed like it lasted forever. It didn't.
Yes.
But so that is expected, and then 12 months without a period is the beginning then of menopause.
Right. So it's hard because a lot of patients want to know, okay, when am I going to go through it? And they want me to tell them, an exact time, but really it's a retrospective thing. We can only know that you went through menopause once you're at that 12-month mark of no periods.
Sure. Is there any genetic link? I've heard that if your mother starts menopause early, you will start menopause early, and that was my case. Is that true?
In general, it is. Most women will tend to follow what their female relatives did, but not always. There's other things that can factor into it, such as when you went through your first period and other medical factors that can play into it. But in general, around the time that your mom or grandmother went through menopause is when you can expect it.
Okay, I can warn my daughter.
Yes.
What about surgical menopause? I've heard that phrase many times.
Yes. So that is when, for a variety of reasons, sometimes if a woman needs a surgery, a hysterectomy, for instance, for a uterine cancer or an ovarian cancer, we may need to take out the ovaries at a young age. So if the woman hasn't gone through natural menopause yet, but then needs her ovaries removed for that reason, cancer probably being one of the more common reasons, then we say that you have gone through surgical menopause. And that differs from natural menopause because, as you can imagine, when you just suddenly take out the ovaries, the symptoms it's like night and day. You just suddenly start getting the massive hot flashes instead of the gradual onset of symptoms that you notice with natural menopause.
Okay.
So at all costs, we try to avoid surgical menopause. For one, because we don't want to put women through having all those symptoms.
Right.
And two, because there are health risks associated with it if we remove the ovaries at a younger age. So if a woman is in her 30s or 40s and we do remove the ovaries, we've actually learned that does increase mortality later in life. After the natural age of menopause, you have a higher risk of cardiovascular disease and other health concerns like osteoporosis. Yeah. So the old way of thinking was really that okay, if a woman is in her late 40s, we can just take out the ovaries. She's going to go through menopause soon anyway. It doesn't really matter. But now we've learned that there's actually a lot of benefit to keeping the ovaries in place. Actually, up until age 65, there are some studies showing that there is some benefit. But that's surgical menopause.
I'm an old RN, and I remember as a young RN
Yes.
having physicians actually state you don't need it anymore.
Right.
Once you
That was the old way of thinking, yes.
Oh, wow.
Times have changed.
Oh, thank God they've
yes.
changed.
Yes.
Now, all right, symptoms. I'm not going to keep talking about myself here. What are the symptoms that are
Yes.
most noticed?
Right. So the most common symptom that almost 80% of women have is the dreaded hot flash. So hot flashes, night sweats, sleep disturbances, mood disturbances, vaginal pain, vaginal dryness. Those are some of the more common symptoms that we hear.
What's out there right now that can help with some of those symptoms?
Well, luckily we live in a day and age where there's multiple options. So the most popular thing that people probably hear about in the media is hormone replacement therapy. So estrogen or progesterone therapy, but that really isn't the only thing. There's also non-hormonal options. So we have certain antidepressants that can be used actually and have been shown to improve hot flashes. So
Really?
yeah, so it's really helpful for women who maybe aren't able to take hormones or don't want to take hormones and don't want to, accept some of the risks that come with that. There are non-hormonal options out there.
When I was in my 50s, I was on hormone replacement therapy, and it was great. I felt really
that's what
great.
most women say, is they feel amazing.
Yeah, you do.
Yes.
And then all of a sudden, my doctor told me no more because of the nurses study. Now, can you talk about
Yes.
not only what they found, but what is different now with hormone replacement therapy than what I may have had when
Right.
20 years ago or 10
Right.
years, 15 years ago?
Right. And that is a very common question I get all the time from patients, because now we're seeing patients who, are getting into their 40s and maybe their moms or aunts, were on hormone replacement therapy back 20 years ago when some of these concerns started to be brought up.
Right.
So the Women's Health Initiative is a large study with thousands of women that most people have kind of heard of, or a lot of the things in the news that you're hearing about hormone replacement therapy are coming from the Women's Health Initiative. So back in the 80s and 90s, there was actually this thought that, okay, so women who are going through menopause and have gone through menopause, we're noticing that they have more cardiovascular risk. Heart attacks, stroke, all of those things increase after you go through menopause. So the question was really, why are premenopausal women not dying as much of cardiovascular disease? And certainly, obviously, age plays a role, but
Right.
there was also this thought that, is estrogen protective? Is estrogen preventing this? And then when you go through menopause, that loss of estrogen is actually putting you at higher risk. And there were some early observational studies back in the 80s and 90s that showed that hypothesis may be true, that estrogen might actually be protective against cardiovascular disease. So physicians were putting their patients on estrogen thinking, well, it's not only going to help, with your hot flashes, but it's also going to prevent, cardiovascular disease,
Right.
Osteoporosis. It's basically
Right.
a wonder drug.
Yes,
And women
was.
felt great, so they loved it. And I think I saw a statistic recently that about 12 million women in the early 90s were on hormone replacement therapy. But then we realized, what? All of this that we're going on is really only based off of these observational studies. So observational studies aren't really ideal in the world of medicine. In medicine, you really want to use data that's based off of a randomized controlled trial. So taking two groups of people who are equal, one group gets a placebo, the other group gets the drug in the study. Well, all of these trials that the HRT was going off of was observational. So basically just women who were going to their doctor, getting put on hormone replacement therapy, and then we were looking at what happened to them. And the problem with that is that those kinds of studies can be fraught with bias, and there can be things that are affecting the results other than the actual medication. So fast forward to the early 2000s, the Women's Health Initiative, the goal was to create a randomized controlled trial looking at estrogen and progesterone, essentially hormone replacement therapy, and looking at, does it prevent diseases long term? So does it prevent cardiovascular disease? Does it prevent osteoporosis? Does it prevent stroke? Not only, it really wasn't looking at, does it work for hot flashes? We already knew that. So then the study was actually discontinued abruptly in the early 2000s.
Yes.
And women were taken off of their medication because after only a couple years of the study, they saw a high risk of adverse effects in women who were on estrogen and progesterone. So namely an increased risk of heart attack, increased risk of stroke, blood clots. They actually did see a decrease in colorectal cancer and osteoporosis, but those beneficial effects weren't outweighed by the adverse effects. So women were taken off of it. And then there was this swing in the other direction where people were afraid to take it. Physicians were afraid to prescribe it.
Big time. I remember being literally told,
yes,
you are now going to just have
very
to deal
abruptly.
with it. Buy a fan, do what you need to do. But boy, what a shock to the system.
Yes, yes, very much so. So I think it's important for people to realize, though, that it doesn't mean that hormone replacement therapy isn't safe. It doesn't mean that you will have a heart attack or a stroke or an adverse effect. It means that we have to look at it in a more cautious way. In the 80s and 90s, it was thought, this, like I said before, this is a wonder drug.
And you can do it for life.
You can do it for life, exactly. Now the thought is, okay, we need to do it short term at the lowest dose possible. And you have to look at every patient individually and really take into account every individual patient's cardiovascular risks. So if I have a patient who has a high risk of having a stroke or heart disease, based on her medical history or her family history, then she might be somebody who I sway towards one of the non-hormonal options. But, I've had patients who are absolutely miserable with their hot flashes. The non-hormonal options, maybe don't work for her. And in that patient, if she's low risk for a cardiovascular event, I might say, okay, we can put you on a low dose of hormones for maybe a year and see how you do.
So you are prescribing it, but less time.
Exactly.
To get over the hump of the symptoms?
And one of the other things that the Women's Health Initiative really found, and one thing that's important to note, was that the average age of the woman in the study was actually, the age range was from 50 to 79. And if you think about it, 79 really isn't the age where you're starting patients on hormones. Most women are in their 50s, and that skewed the results. So I do counsel my patients on that too, by saying that, even though we saw an increased risk of adverse effects, the average age of the woman in the study really wasn't the average age of the patient that I'm seeing coming through my office, wanting hormone therapy. So it really does take an individualized approach, I think, and you have to take a lot of factors into consideration. But to answer your question, yes, there are definitely situations where we're still prescribing hormones.
Hot flashes. Why do people differ? Well, I know we all differ, but I have some friends older than me who swear they have never had a hot flash in my life.
It can happen.
I have experienced with other friends having them now for 15 years. It's certainly diminished, but we still get them now and then, and especially at night.
Right.
What is the difference there? Why is that?
That's another very common question I get from patients all the time, and it's hard to answer. It's not fully understood even what the mechanism is behind a hot flash. We know that estrogen levels have something to do with it, since premenopausal women don't get hot flashes, but that's not the whole story, because even some women who go on estrogen therapy still have hot flashes.
Do they really?
So a big part of it is menopause somehow affects your internal thermostat. So we all have an internal thermoregulation system in our brain, and I always describe it to patients as your, internal thermostat that controls your temperature. And we know that once women get through menopause, that internal thermostat doesn't seem to work as well. And everyone is different in how it works. So some patients might have a very narrow range of temperatures where they feel comfortable.
Yes.
And then as soon as their body temperature gets out of that internal thermostat is out of whack. Whereas other patients have a wider tolerance for variations and fluctuations in temperature. And so I think, genetics definitely plays a role. But to answer your question, it's really not fully understood, but basically the estrogen level and then that internal thermostat.
Well, I think mine has a 1 degree range because
it's possible it does.
I will tell you,
Yeah.
even my husband will notice that there's like at night, I have to have everything right in terms of temperature before I can go to sleep. And he can sleep anywhere at any temperature. But there was, I don't know if you even know who this woman is. She's kind of old now also, but Suzanne Summers.
Yes, I know Suzanne Summers.
She was a big proponent after her acting career was ending on synthetic hormones and wrote a book or guested a book and hosted some shows on it. What was she talking about in compounding all of these things? And
So compounded bioidentical hormones. That's a phrase you might see, in the media and whatnot. But those are hormones that the idea was you can take soy and plant products and make those molecules similar to the estrogen that we make in our bodies. The problem is there's really a lack of regulation with those compounded hormones. So there isn't the stringent safety testing and efficacy testing that we see with the prescription, commercially available hormones that you might get from a commercial pharmacy. So that is really my problem with them. Sometimes they may work, they may make people feel better, but we really don't have any safety studies to go on. So I'm not able to confidently say, yes, take this, you're going to feel better, it's safe. Another problem with it is that it varies between preparations. So one tube of the product might have a certain potency, but then the next tube of the product that you get might be
not.
A little bit stronger, a little bit weaker. And there's really no safety or regulatory board that's looking over these things. So I would tell people if they're taking it, proceed with caution and, really kind of look into what exactly you're using, just because without that oversight, I'm not comfortable recommending it.
No, I wouldn't be either. Okay, that's interesting. Now, so all this stuff seems to start happening to women as we get older, right around menopause time. And there's this whole myriad of things that seem to occur at greater or lesser degree to various women, between hair loss and weight gain and irritability and forgetfulness and just sort of all of this not sleeping well at night.
Right.
What's going on? How often is that? Is there any relief for it other than, now at age 65? Is there any relief for it? Is it, or you just exercise and do the best you can?
So there are studies that show that exercise and diet, it doesn't sound fun, but those are two of the easiest things you can do that have been shown to help with those things. But certainly, all of the symptoms of menopause, namely the hot flashes that I was mentioning before, I think that kind of trickles down to some of the other symptoms. So if you're experiencing frequent hot flashes, you're not going to be sleeping as well. You're going to be more irritable. I think some of it is a chain effect that's happening. So definitely I've had patients who go on the hormones and then they feel great, once the hot flashes get controlled. Then the night sweats aren't happening as often, and then they're not as irritable, and then they're sleeping better. And then they have more time to exercise, so then they lose weight. So I really do think it's all related. We also know that weight gain does occur as we age, as early as age between your age 30 and 40, your muscle mass decreases just naturally. So every year you're losing a little bit of that muscle mass that's normally burning calories. So if you're not continually building up that muscle mass or reducing your calories, even if your diet stays the same, you'll gain weight. And that's actually one of the more common things that patients come to me saying. They're like, I haven't changed a thing that I've eaten, but here I am year after year gaining weight. And that's the reason why, because that muscle mass.
But Dr. Arnold, it seems like women's bodies actually change.
They do.
You know, their weight, their middle gets bigger. Mm-hmm. And there's not even very slender women will notice all of a sudden pants are flapping and waistbands are tight. Mm-hmm. Is that hormone related?
It is. And once women go through menopause, we see a redistribution of the adipose or fat tissue. So not only are you gaining it, it's then redistributing and it's more centrally located.
Why is that? Is it because that stores estrogen better? Or I've heard that. I don't know if that's true.
No, and that's another thing that I'm not sure is fully understood, but we do know that redistribution is happening. So.
Aren't we lucky?
Right. I know. Things to look forward to, right?
Really. It will happen to everyone.
Right.
All right. Now, let's talk then. Let's get off menopause and symptoms and how our body changes as we get older. If I was to come and see you now, what would be the things that you would tell me to watch out for or that I need to do? I'm a healthy 67-year-old woman.
Sure.
What?
Sure. So, typically when women come in for a well woman visit in their 60s, I, review the chart to look at risk factors for gynecologic cancers. We're always looking at that at any age, but especially once women get into their 60s, 70s, and 80s, that's really at the forefront of my mind, just because as we age, our cancer risk increases. So cervical cancer is certainly something that we can screen easily for with a pap test. Typically, those stop at age 65 unless you've had a history of highly abnormal pap tests or cervical abnormalities in the past. But typically, if women have had normal pap tests, then at age 65, those can be discontinued. And a big misconception that we see sometimes is women think, oh, I got to age 65, I'm done with my pap tests, I never need to go to the gynecologist again. And while you may not need as frequent visits, I still think it's important to come in, somewhat often, maybe every few years at least, just to have a well visit and be screened for certain gynecologic cancers.
No kidding. That is absolutely what I have believed, that 65, I now just go to my primary physician.
Right. But sometimes primary physicians, depending on their comfort level with female health, aren't always doing the same exams that we do. So certainly a breast exam is still warranted after age 65.
Right.
I would recommend at least yearly to screen for breast cancer. And then, if women have other concerns, like if they're having symptoms like bleeding or any other concerns, they may need a pelvic exam after age 65. So that's really my goal in women that age, is to make sure that we're not missing, a cancer, especially if they have risk factors. So.
What are the risk factors?
So particularly for uterine cancer, one of the biggest risk factors would be any bleeding after menopause. And I'm always surprised sometimes patients don't realize that even if they have just a little spot of blood, that's not normal after you've gone through that one full year of menopause. So that always needs to be investigated. So that's really the most common symptom. Other risk factors, obesity is a big risk factor for uterine cancer. Family history, and for ovarian cancer, that's also can be genetically related. So if women have a strong family history of ovarian cancer, then I would certainly recommend they still come in periodically to be examined.
Gosh, I am learning a lot.
Well, good.
Let me tell you. Anything else that you can tell an audience of women over 60? Should we be all coming and to you and saying, I'd like to start hormone replacement therapy? Are we too late? Should I be advising my daughter? who's only 30 now, but as she gets older, to, with her regular visit, begin talking about perimenopause and what symptoms she should expect?
Yeah, I think it's definitely a good idea to be proactive rather than reactive when it comes to your health care. So I think, women in their early to mid 40s should, start thinking about some of the questions they may have before they go into that menopausal transition. And then at annual visits, that's definitely something that they can talk with their physician about. Because I think that sometimes when people are going through the symptoms and they're not prepared, then that can be a lot more stressful and troublesome. So definitely I think earlier is better to kind of get on top of these things. And then you asked as well about should women in their 60s be going on hormone replacement therapy. That's really dependent on their symptoms. We know based on the results of that WHI trial that I was mentioning before that really it's the safest when you're younger and going on the hormones, closer to the natural age of menopause. So typically I wouldn't put a patient on hormones after the age of 60 unless she had, failed other non-hormonal options that are available, or if she was, just absolutely miserable despite trying multiple other options. But we definitely wouldn't do it if someone wasn't having any bothersome symptoms of hot flashes at that age.
Here's what I'd like to tell all partners of women who are going through menopause or shortly thereafter. Don't make fun of the hot flashes.
Right.
They are and can be just miserable.
Yes.
They really are, especially if you have 10 to 15 a day.
Right.
So,
and I think that's an important thing to take into account is that, after that WHI trial information came out, a lot of people were scared because of the risks, but a lot of times I think you have to take into account, okay, well, what is your quality of life? And I have had some patients who have said, I don't care what the risks are, I will go to my grave with my estrogen. And I don't blame them,
No, I know.
I don't blame them. If you're absolutely miserable and you're not enjoying life, then, I think it may be worth some of the risks. So.
Thank you so much.
You're
I
welcome.
really have enjoyed this discussion. You are answering all the things that I've wanted to know for a very long period of time.
Good.
I hope you enjoyed this episode of North of 60. If you want information about Dr. Arnold and how to reach her at her office, we will make sure we have that information after this show. Thank you so much for watching.